Welcome to Bona Fide HPP, a podcast designed to educate and support the patients and caregivers of those affected by hypophosphatasia. As a mother and caregiver, host Deborah Fowler has discussions about this rare genetic bone disease with people from around the world. Join Deborah now as she speaks with this week's guest.
Today's topic is one that is of great interest to the soft bones community, and that's the topic of pain management. I'm thrilled to be joined by Dr. Chris Sobey, who's an associate professor of clinical anesthesiology and pain management at Vanderbilt University Medical Center in Nashville, Tennessee. Welcome, Dr. Sobey.
Oh, thank you for having me. I appreciate it.
Oh, well, I mean, you are in high demand in terms of your area of expertise, but I wanted to just take a step back and just ask you how you became knowledgeable about HPP. Can you just tell me the story about how your pain management experience and HPP intersected?
Sure. It was, I wouldn't, maybe not random, but it was not sought out by me. It was interesting. So we have obviously at Vanderbilt, it's a nationally known university with lots of excellent physicians who do a lot of great research. And one of those is Dr. Catherine DeHeer through the endocrinology. Yeah, I'm sure most of many of your constituents are aware of who she is and her impact on hypophosphatasia research. So she manages many of these patients and has realized over time that they need specialized care in pain medicine, and that can be kind of nuanced for a lot of reasons, from oversight, from things like the state boards and DEA, and just trying to optimize patients so they're not we're not contributing to any of complications from the treatment. So she reached out to me, I guess it was about 4 or 5 years ago, and said, "Do you feel comfortable seeing some of these patients?" And at that point, I didn't know much about metabolic bone disorders. Did some research and looked into it myself, saw what was out there, and we've kind of had a referral stream back and forth with these individuals and trying to get them some relief.
That's great. That's really great. I think that finding somebody who takes the time to educate themselves on our disease is something that I'm super grateful for, and I know I speak on behalf of the patients when I say that, because there's just, when you're dealing with rare diseases, such a learning curve, and a lot of times the patients know as much, or in some cases more, than the physicians that they're seeing about their own condition. So that time that you take to learn about HPP is really appreciated. One of the questions that we see quite often, a lot of patients typically rely on Nsaids for their pain management. It becomes almost a routine way of dealing with pain that comes with HPP. What other pain medications can you suggest for the management of day-to-day pain for hypophosphatasia?
Sure. I think that Nsaids are the mainstay for treatment, and that's because most of the data that is available for this patient population is based around Nsaids as the primary. So that's pretty normal question that we get. So a lot of the decisions on how to provide medication management for pain specifically is the pain that's being experienced an acute type of pain, or is it a chronic type of pain? And if it's chronic, and depending on what type of pain they're experiencing, we can help tailor the regimen to be best for the patient and reduce the risk of side effects. So what we try to do with Nsaids actually is recommend them more on an as needed basis for acute issues, acute flares, and acute can be once a week, twice a week, once a month. It can be, there's a variable amount of time, whereas chronic is typically something that patients are dealing with on an everyday basis. They have a baseline degree of discomfort that they have to work through and modulate in order to stay active. So if you are requiring Nsaids more regularly, we would recommend adding actually a baseline scheduled medication that you take daily. And that can help reduce your basal amount of pain from something that is uncomfortable and debilitating to something that might be manageable to deal with. And then we reserve the NSAIDs more on an acute type of scenario. So getting into those medications, things that we regularly use are anti-neuropathic medications or anticonvulsants, things like gabapentin or pregabalin. There are a couple classes of antidepressant medications that are called serotonin norepinephrine reuptake inhibitors. The classic ones we talk about the most are duloxetine, and the proprietary name is Cymbalta. The other two in that class are venlafaxine and Savella or milnacipran.
Okay.
And those medications, although they're labeled as antidepressants, and that can sometimes be off-putting to certain patients because I'm not really depressed. I'm just trying to treat my pain.
Right.
That's not the mechanism of action is actually treating pain. It's not treating. Well, it can also help with depression, but that's not the purpose of why we're prescribing medications. So they have dual uses. There are certain types of local anesthetics that can work. Lidocaine comes in patch formation if it's something that's in a specific location that you use. There's also one called, there's an NMDA antagonist called memantine that can be very helpful for certain types of neuropathic pain. It's also an off-label use for pain, but blocking that specific receptor also can reduce baseline nerve pain, and we've seen that work out in a couple different studies in myofascial pain. And I think something that's gaining a little bit more traction now is oral or intranasal ketamine, which works the same way. It just needs to be dosed correctly so the side effect profile doesn't cause issues. And then lastly, the two last things, and we always talk about steroids being an option for inflammatory mediating pain or bone mediating pain. There are a lot of issues with taking chronic steroids that need to be mitigated. So it's not a great option if taken chronically, but sometimes it's necessary. And then we always, the popular thing now is to dip into talking about cannabinoids and CBD now that it's become a little bit more mainstream, maybe not on the federally distributed level, but state by state, it's becoming a lot more accessible.
Yeah. You mentioned a couple of things I wanted to ask about. One is, a lot of these medications people may not be familiar with. So what's the best kind of way to bring it up to your doctor? I know sometimes patients making recommendations to the doctor isn't exactly well received. But what is your kind of approach and recommendation, advice to patients who hear some of these medications, they're scribbling them down? How do they go about having that conversation with their physician?
Yeah, that's a great question, because I think one thing in regards to pain medication specifically is there's that underlying feeling from both the patient and provider that they don't want to get into the more nefarious acting ones that we always talk about, like opiates. And
Absolutely.
it's a hot button topic, and it has to be broached. And I think that you have to have the right provider, you have to have the right means of communicating this. I think that when you're going into those type of conversations, you're saying, I'm not recommending this medication per se, but I've heard about it. I was wanting to know your thoughts on it, or if you don't have any knowledge of it, could we look into maybe it being an option because it was recommended to me by XYZ. Don't say I need to be on the medication. That's not. You're right. That isn't typically well received. But I think what most providers are trying to do is get patients to be functional with a sustainable regimen. And a lot of times the expectation is, they just want pain medication because they actually don't really want to be out of pain, but they might be wanting it for other social purposes. But that's not what most patients, 99% of patients who come in and we're having these conversations don't have that mindset. And I think that doctors are understanding that more and more, that everyone's just trying to do the best they can with the tools that they have in their metaphorical toolbox. So I would just be open to what the doctors have to say about it. Ask it as more like a question than as a recommendation. ask about trying to learn more about what the options are and why they may or may not be good for you, and try to make sure that the goal is focused more on your functional capacity rather than acquiring a certain prescription.
That's great advice. And I'm glad you mentioned the part about the antidepressants and having the pain mechanism, because that's actually happened to me with my son. I remember when we went in and he was having some pain and they prescribed him an antidepressant. And I said, well, wait a minute, he's not depressed, to your point. And they explained exactly what you explained to me. And I think that that's an important mindset hurdle that you have to get over, to realize that there's other applications for these antidepressants.
Yes. And the thing is, when you have a diagnosis like hypophosphatasia, you're going to have instances throughout your life where you're going to need pain medication that's stronger. You might have a fracture that is just very painful, or worsening
surgery, something.
Yeah,
right.
Surgery, worsening stenosis, that hasn't been operated on yet, or significant arthritic changes that occur. And so you're going to have to have treatment that fluctuates based on your scenario. So the understanding should be, both by patients and providers, is that things are going to change as you move through your life, and you'll need more. Sometimes once you recover from such an instance, you need to come back down, because the last thing you want to do is continue to bombard your body with things that might be detrimental to your ability to stay functional long term.
Sure. We started talking about NSAIDs, and I think that you made a good point that they shouldn't necessarily become a daily maintenance choice for managing pain. Is there kind of a bar you would put around that? A lot of times we see questions about, I've been taking NSAIDs for quite a bit. Am I taking too much? There's also been some studies out there that connect NSAIDs to potentially inhibiting bone growth and potential kidney complications, which are obviously issues in HPP. Is there kind of any bar there, or any kind of advice you would recommend on how much NSAIDs can be too much?
Yes, and the answer isn't a specific dose or a specific duration. It's nuanced to the patient and their scenario. So when patients are on NSAIDs on a regular basis, and I don't mean just scheduled every day, but if they've been taking NSAIDs, just like you said, for months or years, there needs to be some evaluation about from either laboratory findings or other investigations to make sure you're not causing more issues. Because the main side effects that we are concerned about with NSAIDs are kidney complications, specifically reduced kidney function, GI effects, which occurs in about 30 to 40% of regular users of NSAIDs. And that typically, we don't usually just do endoscopies to determine that. We base it on your symptoms. And then if you need to have a referral to GI, we can go ahead and do that. Platelet inhibition, so it can increase your risk of bleeding. And it depends on what other medications you're on and what type of NSAID you're on for that as well. And then lastly, like you said, there's always a concern for bone growth. Now, I'm going to go through these kind of sequentially here. I would say, starting with GI effects, if you're having heartburn or you're having any blackness in your stools, you definitely need to be disclosing that to your physician, because you might need to be on an H2 blocker like ranitidine or something in that class, or a proton pump inhibitor like Prilosec or Nexium, because those can help reduce the acidity in your stomach and reduce those effects. But you don't want to cause things like gastritis or even worse, an ulceration because of your NSAID use. And that has happened even in my practice. Patients typically that are overtaking the medication outside of what has been prescribed, and they can get major complications. And unfortunately, that kind of takes NSAIDs off the table if those happen going forward, which is even more of an issue. Now, in terms of the kidney effects, the reason why that happens is because the whole purpose of NSAIDs is to reduce inflammation, and they reduce something called prostaglandins. And prostaglandins are part of the mitigator of renal blood flow. So when you are reducing those things, you're actually reducing renal blood flow, and when you're kind of starving the kidneys from what they need in terms of oxygenation, and that's what causes death of those nephrons. So what you want to do is keep an eye on patients' renal function, and we usually do that with something called the GFR or creatinine clearance. Those are the two main laboratories we're looking at. So I'm usually looking at that at least annually. Depending on your age group, your primary care doctor might already be looking at that. It's a pretty regular lab that is given out. But if you start elevating, we want to pull back the Nsaid use and mitigate it that way. And then platelet dysfunction more has to do with what is your other risk? Are you on an anticoagulant because you have AFib? Are you on other medications that can cause risk for bleeding, or do you have a fall risk? Those are things to consider as well. And then lastly, the point on bone growth. So this is still a debated issue. This is not something that we have really great evidence on it yet. But what most studies have shown that in the laboratory studies that there is definitely some effect on bone growth in the intermediate stage when you're when NSAIDs are being involved. It doesn't play out as clinically relevant when this is done in patients. So, even surgeons, they used to think, if they have spine surgery, if they have knee replacements or whatnot, they can't have NSAIDs afterwards, because those are surgeries where you need a lot of excessive bone growth afterwards to get stabilization. Mm-hmm. But actually looking at the results for those in patients that were on them and were not on them, it didn't show that there was a high degree of implant mobility and whatnot. So it actually didn't really do that. But what the more recent meta-analysis say, even if you take NSAIDs for 2 weeks after you have a fracture, it doesn't really increase the risk of delayed healing. If you take it longer than that, it can to a small degree, but it's not. We usually try to reserve it to the first 2 weeks after a fracture.
Okay, all right. It's great information. So I don't know if you're aware, but we have a community called HPP and Me, which is specifically for patients. It's on the back end of our website, and we had asked patients for questions to help inform the content of this webinar. And one of them that came up, which I thought was a really good one, was how do we know how do we treat pain that could be caused by a common injury, for example, tennis elbow, versus something that could be caused by calcium deposits in the elbow, because of HPP. You go to the doctor, you're complaining about the pain, somebody who doesn't know about HPP could write it off as, tennis elbow, when really it could be another root cause. So, the question came up about, is there a certain type of doctor that patients should be seeing when they have some of these issues of pain, and really getting to the root cause? And if you had any recommendations around treating pain where we may not know what the root cause is, should we take that extra step and try to get the root cause, or what's your advice around that kind of a scenario?
I think that it depends a lot on the context. Again, these things are going to happen a lot with patients that have HPP or really any all-encompassing systemic disease process, because you are going to be at more risk for less than normal things. We call them zebras in the medical community, actually causing issues than common things. The term is always common things being common. This is probably a bursitis from tennis elbow, something like that. Mm-hmm. But it is true in HPP that you might have some calcium deposits or bone spurring that is occurring, or a microfracture in that same area. So you're going to require an X-ray to really make that clear diagnosis. Whereas if I went to the doctor and I complained about probably the same type of symptoms, it's going to be, well, why don't you do these common things that you would do to reduce a bursitis type of flare, and it'll probably get better. And if that doesn't work, then we get an X-ray. You're going to be more likely to get a more advanced workup earlier if you have HPP or something similar to that. Okay. So, is that worth requesting when you go in? That's hard to say. I think it's worth reminding physicians, whether it be your normal primary care doctor or a specialist, that you do have a metabolic bone disorder, and that it might be things outside of the norm because of that. And so that will require, and they're not going to say, oh, well, you need to get these advanced or painful treatments before they figure it out. But you don't need an MRI of your elbow. You need to get an X-ray first. There's normal steps that you have to do, and sometimes that has to do with getting them reimbursed by insurance, and sometimes it's a exposure to risk for the patient. So we have to, you shouldn't be going in asking for an MRI or a CT scan anytime you have a pain complaint, because that's not necessarily indicated. But
be overdoing it.
Yeah. I mean, you're when you have something like HPP, you're going to be a high utilizer of healthcare services regardless. So it's still important to try to not, I wouldn't say minimize, but modulate it as efficiently as possible. I still think the most common type of physician you should be seeing, though, in this scenario are orthopedic specialists, and they can be either surgical or non-surgical. A lot of patients think that, I got referred to an orthopedic surgeon, but I don't want surgery. The fact is that orthopedic surgeons only see about 25 to 30% of the patients they see are surgical patients. They're seeing a lot of non-surgical patients. So just because you're seeing a surgeon doesn't mean that you're going to get surgery.
You're going to have surgery, or that you're a candidate for surgery.
Yeah, exactly. And so, like, the sports ortho community is usually pretty good at differentiating those type of things. And again, you don't have to be athletic to see a sports orthopedic doctor. You can be, just a normal active person in that sense. Or you could see someone like myself who's in pain medicine, or someone that's a physiatrist who's trained in rehab or physical medicine and rehab. Those are all good individuals to kind of start with if your primary doctor or whatnot thinks that you need a further evaluation.
It's a great point too, because I think just even from a mere convenience standpoint, if you go to your traditional doctor, they're not going to necessarily have the x-rays right there in their offices, where these orthopedists and some of these surgeons or sports medicine doctors will, and they can just quickly send you down the hall for an x-ray. It's kind of protocol in many cases with probably the way they treat patients.
Exactly, and that's what I have patients. Even yesterday came in and we suspected a rib fracture. We sent her right over for x-ray, and it's easy for them. It's easy for us to make that diagnosis quickly and then institute the treatment. So I do think it's worth seeing a specialist in that sense.
That's great advice. I'm going to go back to, you mentioned ketamine earlier. Do you have any experience with HPP patients using low dose naltrexone or ketamine infusions for pain management, inflammation, or also for anxiety and depression?
Sure. I actually don't have any experience with this with HPP because they're fairly new treatments, but I do have experience with them in treating other type of pain. And I think that in terms of extrapolating this to the HPP population, I think that we're just going to have to do a little bit more research on this. The fact is that there's good data to support the use of both. And I'll talk a little bit about low dose naltrexone first. So, naltrexone is an opiate antagonist. So it's the opposite of things like oxycodone or morphine or hydrocodone, et cetera. And it's used at about the 10th of a treatment dose that it was used a lot and still is for addiction. And low dose naltrexone is about a 10th of that dose that people use for addiction. Again, this can be a touchy subject when you're prescribing something that has an indication that can be have some stigma around it, but you're actually, again, using it for a completely different, very viable issue, and that is for pain. It's been shown to reduce symptom severity in patients with things like fibromyalgia, myofascial pain syndrome, Crohn's disease, multiple sclerosis, and complex regional pain syndrome. And there's good promise in some of the studies, but That being said, it's still very early. A lot of these studies have low sample sizes. They haven't been replicated yet in the data. So there's still a lot of work to do, and that'll come as things progress. And I'm imagining it's going to be. I actually, preparing for this podcast, was thinking of my own research opportunities to utilize this in the metabolic bone disorder population. So I think that you're going to see that down the line here. And the reason why this works for pain is not because of the anti-opiate effect, but it actually it has an anti-inflammatory effect as well, acting on it works on something called the microglia in the nervous system, and it reduces pro-inflammatory cytokines that can affect pain. So I think that it would still be deemed experimental in HPP, but I think the risk associated with trialing low-dose naltrexone is very small, and often not something that we are very concerned about compared to other pain modulators. So, and then moving on to ketamine.
I was going to say, yep.
So ketamine it's been known to be administered via infusions for quite some time. It's used in the operating room. It's deemed an anesthetic because it alters your sensations and ability to function at certain doses. But it's also a very potent analgesic, and it's been growing more and more popular, both in the operating room, in the ICU, and now in the clinic and outpatient space, because it's an alternative to things like opiates that we know can be more have more issues long term, whether it be dependence or just side effects from the medication itself. The issue that we run into with ketamine are kind of two things. The first is the administration, or the data that we have behind its administration is mostly in infusions. And obviously when you get infusions, it's kind of a bigger ordeal. You have to get an IV, you have to stay in a certain location for a certain amount of time. Some of the data behind the infusions is really high doses where you can be very altered, and you require kind of anesthetic complements to make it tolerable, which is not a realistic treatment for a lot of patients trying to get their pain under control. And a lot of the trials only show 1 to 2 weeks of improvement after these infusions. So how replicable is that in the population? The other thing is, it's not usually covered by insurance to a great degree, or if at all. And so a lot of patients are doing cash payments for this, and that can be very costly. But that being said, the FDA has already approved nasal ketamine for outpatient use for depression, and we use it for neuropathic pain on a regular basis, or intractable pain. And we have some good data that's coming out in that sense. It again, just like naltrexone, has not been studied specifically in patients who have HPP, but it has the promise to be in the future. And I definitely think it is a good alternative to opiates, because the fact is that things like ketamine, it doesn't cause morbidity and mortality, whereas opiates have significantly altered the face of the United States and the world, actually, and the issues.
Yeah. Well, I know that so many people are going to find all of this so interesting. There's going to be a lot of discussions happening with those doctors. I'm glad we touched on that a little earlier.
Yeah, absolutely.
So there's one final question I want to get to, and that's about gabapentin. Is it known to cause short-term memory loss if used long-term?
It really is only known to cause memory issues or cognitive dysfunction while you're taking the medication. Okay. The extrapolating that out to where you've taken it for years and years, and there's no, as far as I'm aware, in terms of the research and the literature that we look up, discontinuing the medication at a certain time, you don't have less cognitive function than you would if you were not on that medication, ruling out other causes. You're going to have memory issues as you age, irregardless. It's an unfortunate part of how we were created and how our bodies work moving forward. But there really wasn't any statistically significant difference in the memory abilities of patients that had been on gabapentin and then stopped it versus people that had not been on it at all. Now, when you're on the medication, that's a different story. So the purpose of how gabapentin works is it works on calcium channels and on neurons. And the purpose is to kind of reduce the hyperactive neurons. And that can be for pain and what we're talking about, or it actually is used for seizures and as well, and can reduce abnormal excitement in the brain and reduce seizures for that point. So what you have to remember is when you're reducing hyperactive neurons and their functioning, because your goal is to reduce pain, your brain is a large conglomerate of hyperactive neurons as well. And that's one of the issues about taking pills or things that go systemically throughout your body is you're not isolating, your arm pain, or you're not isolating your back pain or whatnot. It distributes with indifference throughout your body. And so that's why you can have, some short-term memory issues or some dizziness or some balance issues, because it is reducing those neurons as well as the pain fibers. So, but typically when you stop those, your body recovers pretty quickly.
Okay.
Yeah, I would say that one note of caution: if you are on gabapentin and you're, depending on your dose, if you're having any side effects, you do want to taper down off of that. It's not something you want to go from a full, you don't want to go from a full dose to zero. You actually can induce some seizures because that causes some excitability in the brain. And so I would say if you're having issues, contact the prescribing provider before you make decisions to discontinue.
Okay. Gosh, that's super important. Okay. Well, Dr. Sobey, this has been incredibly helpful. Thank you for sharing your experience, your expertise with us today, and we look forward to continuing the discussion in the future.
Absolutely. Thanks so much for having me.
And that's it for today's podcast. You've been listening to Bonafide HPP, a podcast of Soft Bones, the U.S. Hypophosphatasia Foundation.
Join Deborah and other patients on HPP and Me, where they continue discussing questions around hypophosphatasia and submit questions for the next podcast. Go to softbones.org and click on Community, then HPP and Me for instructions on how to sign up. This podcast and the intro music was produced and edited by me, Patrick Jaguar.